Fetal and Neonatal Neurology SIG. And today also we'll be having one webinar followed by 5 interesting case presentations on fetal and neonatal neurology. I'd like to request the President Dr. Shapalavuti ma'am to introduce the speaker for today's webinar, the experts, and the moderator for today's session. Over to you, ma'am.
Thank you. Thank you, Mahesh. Welcome for this talk on fetal neurology. And this talk will be taken by Dr. Karuna Shekhar, which indication for fetal MRI, common MRI abnormalities and counseling of the family, which is a very common situation which we face. And we will be having experts from across different resource settings, Lokesh Lingappa, Dr. Uzur Uzdin, Dr. Smita Manchanda, and Dr. Nitin. Can I have the CV slides, please? Can I have the CV slides? CV slides, yeah. So Dr. Karuna Shekhar is Associate Professor of Clinical Radiology, Children's Hospital, Philadelphia, University of Pennsylvania, Philadelphia, USA, with over 25 peer-reviewed publications and over 15 book chapters. She's interested in pediatric and neonatal EEGs, and her area of interest is fetal neuroimaging, pediatric brain tumors, and she got a De Monte gold medal in diagnostic radiology and diploma in medical radiology and electrology, India. Then we'll be having experts. The first expert we have is Dr. Lokesh Lingappa, who is consultant child and adolescent neurologist, Rainbow Children's Hospital, Banjara Hills, Hyderabad. And he has also had fellowship from the UK. He's been awarded as the best outgoing neurology student and received travel grant fellowship from the ICNA. And he's a very dear friend and a president-elect of AOC and next year. And we have Dr. Smita Manchanda, additional professor, Department of Radiodiagnosis and Interventional Radiology, AIMS, New Delhi. And she has a subspecialty head of women's imaging, ICRI 2024. And she has interest in women's imaging and head and neck imaging. And she has co-editor of 2 books on clinical radiological series, besides couple of awards and publications to her credit. And we have Dr. Nitin Gonge, who is senior consultant radiologist and academic coordinator, Apollo Hospital, New Delhi, who's course coordinator, Del Red radiology resident courses, and many affiliations in national and international fora, and has RSNA Editors Recognition Awards multiple years, and many more awards and orations, and many publications and presentations, and is interested in obs and gynae imaging besides others. And we also have our friend from Turkish doctor, who is Dr. Ozgur Özektin. He's a clinically active pediatric neuroradiologist and consultant neuroradiologist at Hamad Medical Center, Doha, Qatar, who's graduated from the Hacettepe University and Faculty of Medicine and trained in general radiology at Tepesik Education and Research Hospital with special interest in fetal imaging and brain tumors. His main areas of research are posterior fossa malformations and strong interest in education, and is currently involved in the International Network for Evidence-Based Research in Clinical Health Research in the European Cooperation in Science and Technology Action. He's author of over 100 original peer-reviewed publications and was awarded the Teach the Teacher certificate by the ESM RMB. Now I hand over to our moderator of the session, who is Dr. Prashant Johri, who's my colleague and working as additional professor in pediatric neurology in Department of Pediatrics, AIMS, New Delhi. Over to you, Dr. Prashant.
Thank you, ma'am. So I welcome everyone for this session on fetal neurology. I will especially want to thank all the delegates who would be presenting cases this time. So without spending much time, I'll ask Dr. Karuna to start with her deliberation. Over to you, Dr. Karuna.
Thank you. Thank you.
As time permits. So the objectives of my talk are to discuss fetal ventriculomegaly and especially focusing on the role of fetal MRI, and then briefly touch upon some other indications. So, for any fetal imaging, the primary imaging modality is going to be ultrasound, and MRI. The role of MRI is basically the assessment of sonographic findings. And MRI, it should be noted that it is not a screening tool. We follow the guidelines which have been set by the American College of Radiology, but I think they are applicable universally. So, there's a lot of literature, which has been put forth since we started doing, the late, in the 1900s and 2000, we started doing fetal MRI here at our institute at CHOP. And there's a lot of literature which keeps coming on this particular topic of fetal ventriculomegaly, which is indeed one of the most common, indications for fetal MRI. And before we go on to talk to that, I just want to briefly discuss, like, why do we do MRI? Because there is limitation in the evaluation with ultrasound, particularly if there is oligohydramnios relating to patient's maternal body habitus. Fetal position sometimes can be unfavorable if there's an anterior placenta. And then if we need detailed evaluation of the entire, multiple systems, particularly if it's a complex, multi-system anomaly. And MRI offers inherent superior tissue contrast and signal to noise ratio. Again, emphasizing that MRI is not a screening tool, and it is completely safe. It does not provide any danger, and we do not do MRI in the early trimester when it is the phase of organogenesis, and we do it only for suspected abnormality. And the whatever theoretical risk, it outweighs the benefit outweighs the minimal risk which may be present in doing fetal MRI. The image acquisition, usually we do most of our work gets done on a 1.5 Tesla scanner. We start with a phased array coil. We do a coronal localizer followed by imaging in orthogonal planes. Usually they are 30-second, images, each sequence. Usually we finish the entire study in about 35 to 45 minutes. And we are not offering any maternal sedation when we do this. We advise the patient to do quiet breathing. And one of the tips is that we tell the mom not to consume any high sugar food or beverages, at least 1 hour prior to the MRI study, just to keep the fetus calm and so that we minimize the motion degradation. The bulk of our sequences, usually done with heavily T2-weighted sequence, which is a haste on our usually on the Siemens scanner. This is what we do, and we do employ these other, the technical factors that we employ, and we get good detail, of the CSF and the brain parenchyma and the extraaxial CSF as well on these images. We also utilize specifically in MR the gradient echo sequences, which offer us a great visualization of any blood products, of any of the mineralization or bony structures very well. We do it at at 2 parameters so that to have like an internal control, because to distinguish between germinal matrix, which can be pretty bulky compared to actual hemorrhage. And T1 weighted images, which usually have a low utility in the weeks earlier to 28 weeks of gestation. So we use it only in the later phases. So one of the most common indications for fetal brain MRI is ventriculomegaly. And some other indications which also are there are primary malformations which happen, but several of these, if you will see, and as I'll show in the cases, many of them also include ventriculomegaly as a part of their findings. So ventriculomegaly is not a diagnosis, it is a finding, and you put it together along with other findings to actually come at a diagnosis. And some of the other indications include, secondary injury or clastic injuries, and all of these again, which can not be in isolation. You could have a malformation and you could have a secondary, clastic injury happening, and they cannot be put into like watertight compartments. And so you do get ventriculomegaly as a part of both primary malformations as well as secondary injury, or in the combination of these entities. And then some of these are some of the spine indications. I don't know if we'll have time. We'll go through that, emphasizing on the myelomeningocele, because that is one of the conditions for which we offer fetal surgery. So, and these are some of the other indications. I will jump straight away to talking about ventriculomegaly. So as I said before, this is the most common indication for fetal MRI, with an incidence of about 1 to 2 per 1,000 births, and it can be isolated or it can be present with other anomalies. And this is more often, the presenting finding, but it can be the tip of the iceberg, because there could be, several other anomalies which can be associated just with ventriculomegaly. The ventricles usually, develop, and in the beginning, in the early trimester, they occupy nearly 80 to 90% of the brain. But actually, as the brain grows, it then develops into occupying nearly about 30% of the calvarial volume, if you say, as the cerebral hemispheres grow, the posterior fossa structures grow and mature. But one of the things that we want to say is that the atrium of the ventricle, lateral ventricle, it's starting from like the second trimester, or say about 18 weeks, it almost nearly has a constant diameter throughout. That is why we use the atrium of the ventricle to be that's why we use the atrium of the ventricles to be the region where we measure. So we measure in the atrial diameter, and if it is above 10 millimeters, which is more than 2 standard deviations above normal, which is about 6 to 7 millimeters. And what is the difference between ventriculomegaly and hydrocephalus? So ventriculomegaly is just referred to as enlargement of the ventricles. It could be either unilateral or bilateral, which is identified in utero, whereas hydrocephalus is ventriculomegaly with increased CSF pressure, and usually has obstruction as the etiology, and oftentimes is associated with head circumference. So typically we use the term hydrocephalus in the utero imaging only if we see definite evidence of obstruction and increased pressure as a part of the obstructive etiology for the ventriculomegaly. So here is now the spectrum that we see, and we divide the ventriculomegaly based on the size. Mild is 10 to 12 millimeters, moderate is 12 to 15 millimeters, and severe is greater than 15 millimeters, as you can see. And this is the normal, which is usually about 6 to 7 millimeters. And this is where we measure. Usually we have the choroid plexus. We use a good symmetric image at the level of the thalami. You have the choroid plexus here. You draw the line usually along the posterior margin of the choroid plexus. And sometimes it can be challenging if it's an extremely motion degraded study, but you try to use your best axial image. People have also talked about measuring at coronal images, but we don't use that in practice. We usually use the measurement on the axial image. And typically we find that there may be a little discordance between the measurement of the ventricles, which is seen on ultrasound, versus MRI. MRI tends to measure it to be a little bit higher than the ultrasound. But we know that this has been used as a reference, and fairly consistently using the diameter at the atrial level as the size to assess the ventricles or to classify the extent of the ventriculomegaly. And the etiology of ventriculomegaly can be varied. Basically, again, like the postnatal ventriculomegaly can be divided into two groups. You can see it can be either obstructive or non-obstructive. Obstructive could be the typical, non-communicating, with the pathology being intrinsic to the ventricles, like, say, aqueductal stenosis or posterior fossa malformation. It could also be a result of post-hemorrhagic or post-infectious etiologies, or the cause could be outside the ventricle, which, as we see in the case of a Chiari malformation or hemorrhage or even a tumor. The communicating obstructive hydrocephalus is usually a result of decreased CSF resorption, which typically arises because of hemorrhage. Non-obstructive causes can be due to overproduction, which only one example which we can see, even though we have this tumor, it's rare that it really produces that much, rarely with choroid plexus mass lesions. Malformations like corpus callosal agenesis, the holoprosencephaly spectrum, and the host of the disorders of proliferation, differentiation, migration, genetic abnormalities, all of them can have the ventriculomegaly as a part of their findings that you can see. And a big group, which also we can see ventriculomegaly, which is more as an ex vacuo dilatation when there is insult due to any vascular causes, ischemic, or a host of infectious causes, can all produce ventriculomegaly. So we go to examples of mild isolated ventriculomegaly. So this is an example here, which is usually less than about 10 to 12 millimeters, as we said. And usually, if we don't see any other abnormalities associated with it, like hemorrhage or any areas of cortical malformation or any other abnormalities in the rest of the brain as well as in the fetal body, then we usually counsel this to be a good prognosis. Compare that to this case, extreme case. This is, severe hydrocephalus, and notice here that you have an obstruction which is at the level of the aqueduct. The extent of the ventriculomegaly is pretty severe. And on the gradient echo images, you can even see a little bit of staining of the choroid plexus as well as the margin of the ventricles, because this is under pressure and it can lead to tears of the ependymal lining, or, it can result in blood products which produce susceptibility and are very well seen on the gradient echo images. And here is an example of the same with postnatal CT. And one of the causes of aqueductal stenosis can be related to a genetic abnormality, which is seen with X-linked hydrocephalus in males. It is 20% of the congenital cases of hydrocephalus associated with an L1-CAM mutation. Adducted thumbs are one sign that can be seen, but it is not necessary that you need to have this finding. And then more recently, there has been literature and cases which have shown that you get an association of the diencephalic, mesencephalic junction disjunction, which is very commonly associated in this disorder. Moving on, this is an example of a Dandy Walker malformation. Now we have new criteria which talk about the tegmentovermian angle here, which is obtuse, it is elevated. You can see a high position of the torcula and hypoplasia of the vermis, this large CSF structure filling the posterior fossa along with severe ventriculomegaly. So this is a classic appearance of Dandy Walker malformation. Again, this can be isolated or can be seen as a part of other associations and syndromes. Here is an example. Here we have, again, ventriculomegaly, which is sort of in the moderate category. But if you notice, there is absent corpus callosum here. And you can notice if you look that there is a little bit of nodularity to the ventricles here. As it is pointed, it can be subtle. And the classic findings of colpocephaly, or the coronal image showing the Texas steer horn or the bullhorn appearance, which can be seen in the coronal plane. So we have corpus callosal agenesis. This is a female fetus, and when you see the findings of nodularity and typically findings of a coloboma, this is a case of Aicardi syndrome. So you can see that you cannot have the satisfaction of search with just finding.
Can be divided into two groups. You can see it can be either obstructive or non-obstructive. Obstructive could be the typical, non-communicating, with the pathology being intrinsic to the ventricles, like say aqueductal stenosis or posterior fossa malformation. It could also be a result of post-hemorrhagic or post-infectious etiologies, or the cause could be outside the ventricle, which, as we see in the case of a Chiari malformation or hemorrhage or even tumor. The communicating obstructive hydrocephalus is usually a result of decreased CSF resorption, which typically arises because of hemorrhage. Non-obstructive causes can be due to overproduction, which only one example which we can see, even though we have this tumor, it's rare that it really produces that much, rarely with choroid plexus mass lesions. Malformations like corpus callosal agenesis, the holoprosencephaly spectrum, and the host of the disorders of proliferation, differentiation, migration, genetic abnormalities, all of them can have the ventriculomegaly as a part of their findings that you can see. And a big group, which also we can see ventriculomegaly, which is more as an ex vacuo dilatation when there is insult due to any vascular causes, ischemic, or host of infectious causes, can all produce ventriculomegaly. So we go to examples of mild isolated ventriculomegaly. So this is an example here, which is usually less than about 10 to 12 millimeters, as we said. And usually, if we don't see any other abnormalities associated with it, like hemorrhage or any areas of cortical malformation or any other abnormalities in the rest of the brain as well as in the fetal body, then we usually consider this to be a good prognosis. Compare that to this case, extreme case. This is, severe hydrocephalus, and notice here that you have an obstruction which is at the level of the aqueduct. The extent of the ventriculomegaly is pretty severe, and on the gradient echo images, you can even see a little bit of staining of the choroid plexus as well as the margin of the ventricles, because this is under pressure and it can lead to tears of the ependymal lining, or it can result in blood products which produce susceptibility and are very well seen on the gradient echo images. And here is an example of the same with postnatal CT, and one of the causes of aqueductal stenosis can be related to a genetic abnormality, which is seen with X-linked hydrocephalus in males. It is 20% of the congenital cases of hydrocephalus associated with an L1-chem mutation. Adducted thumbs are one sign that can be seen, but it is not necessary that you need to have this finding. And then more recently, there has been literature and cases which have shown that you get an association of the diencephalic mesencephalic junction disjunction, which is very commonly associated in this disorder. Moving on, this is an example of a dandy walker malformation. Now we have new criteria which talk about the tegmentovarian angle here, which is obtuse, which is elevated. You can see a high position of the torcula and hypoplasia of the vermis, this large CSF structure filling the posterior fossa along with severe ventriculomegaly. So this is a classic appearance of dandy walker malformation. Again, this can be isolated or can be seen as a part of other associations and syndromes. Here is an example. Here we have again ventriculomegaly, which is sort of in the moderate category. But if you notice, there is absent corpus callosum here, and you can notice if you look that there is a little bit of nodularity to the ventricles here, as it is pointed. It can be subtle. And the classic findings of colpocephaly, or the coronal image showing the Texas Huron or the bullhorn appearance, which can be seen in the coronal plane. So we have corpus callosum agenesis. This is a female fetus, and when you see the findings of nodularity and typically findings of a globoma, this is a case of Aicardi syndrome. So you can see that you cannot have the satisfaction of search with just finding one finding. Here we have ventriculomegaly, we have corpus callosum agenesis, but you need to go and extend your search to look for other abnormalities, because the constellation of findings could lead you to the diagnosis of a particular syndrome. We go ahead. This is another case of ventriculomegaly associated with malformations, and this is a classic malformation where we have a small posterior fossa, hindbrain herniation, an open dysplasic defect with myelomeningocele. This is a Curie2 abnormality. This is a cross-section of the myelomeningocele sac, and these are the axial images from the brain which demonstrate the ventriculomegaly. And notice that in this ventriculomegaly, most of the times this is reactive, this is not under pressure. So we also have in Curie2 malformations a little bit of a dysmorphic appearance and more posterior enlargement of the ventricles, because the corpus callosum usually is developed and present in the anterior part, but maybe hypoplastic or dysplastic in the posterior aspect of the splenium of the corpus callosum. Here are some examples now of ventriculomegaly, which can be seen with various clastic lesions or various insults. For this one here, you have more of an isolated or like a asymmetric ventriculomegaly, where we have enlargement of the right ventricle with presence of cysts, and if you have, usually may have association of hemorrhage here, and you can identify this to be an ex vacuo ventriculomegaly. In this case, the gradient echo images show a large journal matrix hemorrhage, which has resulted in enlargement of the ventricles and extension of this into the parenchyma, which qualifies this for Greek for germinal matrix hemorrhage, and again asymmetric ventriculomegaly. And this is an extreme case where of hydranencephaly, where there has been extreme, the ventricles under pressure, and there has been disruption of the ventricular margin with very minimal or if any of cortical mantle remaining. This is a case with hydranencephaly, which depends on the time you image. If it may, at one point, it would have been a very severe hydrocephalus, and this is the stage when we are imaging now, where there has been destruction of the ependyma and very little cortical mantle remaining. So these are examples of ventriculomegaly which is associated with destructive or clastic lesions. And now we look at the malformation spectrum. So I have a series of the holoprosencephaly spectrum. You can see this is a case of a lobar with a monoventricle here. There is a little bit of better improved division in this case of lower holoprosencephaly, but you still see non-fusion or non-separation of frontal. Here you see a limited separation, and this is more of a semi-lobar holoprosencephaly spectrum, but you notice what is common to all of this is a ventriculomegaly. So again, to illustrate the point, ventriculomegaly is just a finding which can be associated with malformative, destructive lesions, and also to now what I'm going to show you is a series of cases of ventriculomegaly with abnormalities in the brainstem, particularly brainstem kinking. So notice this one. This is the first case where you have a kinking of the brainstem in association with the ventriculomegaly. And in this case, there is another finding, which there is microphthalmia. And when you put these findings together, this is more likely to be some kind of an alpha-dystroglycanopathy, especially the Walker-Warburg or other eye muscle brain diseases. Here is again another kinked brainstem, but the other finding associated with it, if you notice, is along the ventriculomegaly, is a very dysplastic appearance of the bilateral basal ganglia. And you have this very typical appearance of the ventricles, the flask-shaped appearance, which is very classic for tubulinopathy. This is another case of fetal MRI where you have, because tubulinopathy is a spectrum, but the overriding finding is the dysplastic appearance of the basal ganglia, the typical dysmorphic appearance of the frontal horns. This is a TUB1A mutation, which is one of the more common of the tubulinopathies. And sometimes you basically don't get an answer to actually watch the abnormalities if you don't have a follow-up. So this is another case with a kinked brainstem, but this was having a more sort of elongated appearance of the tectum, as you can see in this case, and small cerebellum and severe ventriculomegaly. And with this, you might assume that this could be a L1CAM mutation. And not just in this case, there are several cases on fetal where if you don't get a follow-up or postnatal imaging or some kind of genetic testing, you just postulate, but you may sometimes not get an answer, or it could be something new for which we still don't have information. So some of the entities that you need to think about for ventriculomegaly with brainstem kinking are the alpha-dystroglycanopathies, typically the Walker-Warburg, muscle brain disease, and Fukuyama's dystrophy. The other conditions include X-linked hydrocephalus, L1CAM mutation, and tubulinopathies. We talked about that. We saw a series of these things, and let's talk about outcomes. Now, it can be very difficult to predict what is going on. There have been literature supports, this large review series, with isolated mild ventriculomegaly, nearly 30% resolved by the time the patient reached term. About 57% they stabilized, did not progress, but there are a few which progress. So a lot of factors of the outcome depend on, these several things that go on. So what do we do to kind of, when we see ventriculomegaly? You want to do a workup because several can be associated with other CNS and non-CNS abnormalities. The incidence, of having a poor outcome increases with the severity of ventriculomegaly. There is a host of chromosomal abnormalities that can be associated with it. Usually, these are associated in about 12% of isolated ventriculomegalies, But nearly, if you consider all ventriculomegaly cases, nearly 40% will be associated with chromosomal abnormalities or aneuploidies. And a big group, which we have not yet seen cases, which is the intrauterine infections. They account for about 5% of all ventriculomegaly cases, particularly for severe ventriculomegaly, then about 20% of the times they are associated with infections. So the workup, because of this, will include a detailed anomaly ultrasound scan. And fetal MRI, you do it in most of these cases because literature supports that there are at least about 50% of cases MRI will add findings which may not be or difficult to be seen by ultrasound. Most of these cases will get touch testing, thrombocytopenia screening, karyotype testing, and as needed fetal echocardiography. So you need to have a very robust checklist when you're seeing these cases. You, in addition to looking at the vertical size, you want to look at the outline to look for nodularity. You look at for the ventricular septations, presence of any cysts or calcification. You look for ventricular vaginal matrix hemorrhage. Then you turn your attention to the parenchyma to look for any cysts, signal abnormalities, pay special attention to the aqueduct sylvius for any narrowing, presence of any web or mass. Look at the septum pellucidum, corpus callosum, and posterior fossa structures in detail. Look at sulcation, what is going on with the fetal brain, and pay attention to that correlating with the age of the fetus. Attention to the overall head circumference and any extracranial malformations to suggest any complex or chromosomal abnormality. Now, we looked at all these, cases, and when we want to talk about outcome or discuss it, it's not, it's a teamwork. It's a multidisciplinary team that looks at these cases, which includes, after the imaging is done with the fetal medicine specialist, we look at discuss that with with a neurologist. And in addition, as needed, geneticists or even a pediatric neurosurgeon is on board, particularly to look or discuss findings or things that may need to be done postnatally. So this is the entire team which usually is involved in the discussion after we report. So if it's non-ventriculomegaly, it's fine. It's usually the expected prognosis is good in more than 90%, and you counsel them as good prognosis. But it's not as simple. There are challenges because there still is an overall prevalence of developmental delay in about 8% of these cases. You have literature which tells that there can be neurocognitive and behavioral issues, even though it is mild ventriculomegaly. So there's a lot that we don't know, and this ventriculomegaly is just a finding. So there still remains, things that we may not be able to identify at the fetal age, and these cases may need postnatal imaging to truly assess the best, outcome for these cases. Now, I want to show you this one case, which just will highlight, how challenging it is to counsel these patients with ventriculomegaly. And this is an actual case, and I have actually included some screenshots of what is included in the patient's chart for discussion, particularly here in the US, since things are pretty high on the medical legal aspect, and you need to be careful that you've covered all your bases when you discuss something which is so sensitive as this matter. So here is a case where this was a report for a fetal MRI for 30-week gestation, ventriculomegaly, and quite often that's just the one-word history that we get. So this was the MRI that was done, and of course you see findings of ventriculomegaly. One other finding which was noted or which was put down is that if you notice the cortex on this side compared to the right side, it does not show, it's more kind of flat. It does not show the extent of the cortical sulcation that would be expected for the right side. Now, it's unclear, so this is at 3 weeks gestation, whether this is just a finding which is related to the extraocular enlargement of the ventricle, or is it truly a abnormality? So this will basically need to be assessed in the later stage, or follow up in pregnancy to see what is going on. But it is really imperative that we put this out, that there could be not just isolated ventriculomegaly, but there could be a potential, dysgenesis of the cortex here when you compare it with the other side. So this is exactly how this was, the report was made out. And here is the actual screenshot of this fetal neurology clinic note. So this is basically included in almost all cases that get counseled here. They literally kind of write all the recommendations made by the Society of Maternal Fetal Medicine here, and they have listed everything which is related to mild to moderate, and what is the outcome. It does not finish here. You have another page here. They give complete listing of potential risks or what could be associated with the ventriculomegaly. It's basically offering various options which is given. But I also want to highlight that they do discuss and say that you have to repeat ultrasound serially, but you have to get a newborn head ultrasound or brain to further evaluate any things, because several things may be not identified prenatally on the fetal MRI. So a lot of caveats and a lot of exceptions to saying that it's not as straightforward as saying it's all good, but you basically are telling that there could be many things which we don't know or cannot be identified on the fetal MR. But literally, this is how the counseling goes out. And if it is mild, they may say that reassuringly that most of the time, doing a higher percentage, that it would have a good outcome. But basically, because of the potential things which may not be identified on fetal MRI, this is the way, in a very guarded manner, that all this counseling is given to the patient. I think at the extremes, when there's nothing, like if it's severe ventriculomegaly, you know that the prognosis, it's more straightforward, black and white. But when it is kind of like in the mid-range or on the lower spectrum still, you have to give the potential thing that there could be something which we cannot tell at this stage. And this is a plan which is measured out or given to the patient, that you continue obstetric management and serial ultrasounds. You repeat that ultrasound and postnatally obtain an MRI, do a neurological evaluation, and then close monitoring, with the pediatrician to see that the kid is growing well, and as needed, postnatal neurosurgery and genetic counseling. So it's basically covering, all these specialties, and even in a case of sort of somewhat, not related when other outcome or other abnormalities associated, you still give a very kind of a guarded prognosis, given that there could be a chance that something could be messed on fetal. So just to give the summary on ventriculomegaly, there are a few things that we know for sure, is that the severity of the ventriculomegaly is a single indicator that affects outcome. Progression of ventriculomegaly through the course of the pregnancy is also associated with the poor prognosis, and the survival usually drops with increasing or progressing ventriculomegaly. And associated abnormalities, genetic defects, and infections, they affect the outcomes, and detailed evaluation of the rest of the brain, CNS, and body is needed, with an important facet of parental counseling. So when we say all this, just need to be aware of the limitations of fetal neuroimaging. And I'm showing you cases with very selected, very good cases, but you have to be aware that nearly 80% of the fetal MRIs, they have a lot of motion degradation on the images, and you basically have to read out the good sequences to get this information. And oftentimes, neonatal MRI is needed for the further assessment, and you cannot make a complete diagnosis. You're limited on the fetal MRI. So, having said that, I just want to turn my attention to a few other examples. I don't know how much time I have. Can I go on for another 10 minutes? Basically. Yeah, okay. I'll just try to be brief and show a few other examples. So I want to show this one starting with some vascular abnormalities I think will be of interest to the neurology group. So this is a case of as it is obvious, a venovagal malformation, the persistent prosencephalic vein. You can see the saccular dilatation here. This is basically a direct epidural fistula with enlargement of the sinuses. And oftentimes, this is how it is present in the fetal life, but it can expand, it can lead to real ventriculomegaly, and can also end up with a lot of white matter injury if there is no treatment or done. That is usually the outcome or the normal course of these kind of conditions. And here is a postnatal MR, which shows slight increase of progression in the size of this vein of Gillen malformation, and you can see a recruitment of a lot more vessels feeding into the vein of Gillen malformation, which is not that evident or has progressed since the fetal MRI. So this is one of the other indications that we commonly see which come for fetal evaluation. Most of the time, this is basically to be aware of what to expect when the kid is born, and we also offer many of these complex cases, fetal MRI cases, to get delivered in what we have a special delivery unit so that the history is known and supporting staff for the imminent delivery and postnatal management is readily available. Another case example I have here for vascular abnormality for which we see in fetal MRI indications is what we call the dural sinus malformations, where you literally have a large giant aneurysmal dilatations of the fetal venous sinuses. But the tortula is a very common location. Many of the times you can see some thrombosis or hemorrhage within. But many of the times, particularly if they are at the tortula and if there is no other white matter involvement, they have a pretty decent outcome. For example, in this case, you can see this follow-up postnatal MRI. We basically see that this dural sinus malformation has literally shrunk to this stage, and this one, the rest of the venous sinus, dural venous sinuses are normal, and this was a pretty good outcome for this patient. And now I just want to briefly talk about one of the other big group of indications fetal for MRI, which we get are for the myelomeningocele with KRE2 malformation, and want to talk about this MONS trial, which is the management of myelomeningocele surgery for in fetal repair of myelomeningocele. And MRI plays an important role in deciding the candidacy of these patients whether they're suitable for fetal MRI. So here is a classic example of a KRE2. You can see this hindbrain herniation, ventriculomegaly, the citric defect. Here it is in the axial plane with a big myelomeningocele sac. And this is another example where you have sort of a small posterior fossa hindbrain herniation with a smaller sac. This is an example of a smaller sac myelomeningocele, and if you notice in this case, the mother actually also had a history of a spinal dysraphism, which has since been repaired. Probably she also had a myelomeningocele, and even the fetus has a myelomeningocele. So this is not genetic, but this is just one example where both the mother and the fetus have this myelomeningocele, and they can be open defects without a protrusion of a sac beyond the skin margins, and that would be a myeloschisis. Both these cases, open dysraphisms associated with KRE2 malformations and hindbrain herniation. So, want to talk about this study, which is a very landmark study, which was done, and there is also the study, the MONS study, which stands for the Management of Myelomeningocele Study, which was published more than 10 years ago. Here, this was actually in 2011, where they actually did randomized the patients into two groups. One who had a fetal surgery, they actually went in and closed the sac, and versus the other group, the trial group, which did not have surgery. And the results were so encouraging that that the fetal with the ones which had repair postnatally were less likely to have a ventricular shunt because the CSF dynamics improved. hindbrain herniation postnatally was less common in the patients who had the fetal repair, and even the motor skills in the group that had surgery were extremely good outcomes, and many of the kids were walking independently, and some of them we have seen we follow up are actually even into sports and tennis and ballet dancing, which is a very encouraging thing in terms of these kids who have had a fetal repair. This is one of those studies where the study was so successful that they actually closed the study early so that the benefit of field repair could be offered to other patients, because this was without a doubt a benefit in this case. So here is an example where we saw this case with the myelomengocele. Usually this field repair is done at about 28 weeks of gestation, and you can notice in this case, after the fetal repair on this fetal MRI, you can see that the sac is closed. This is the axial image. And you notice here, there was effacement of the CSF in the posterior fossa, and after surgery, you can actually notice that there is adequate CSF here in the posterior fossa. Although we still have a low neural plaque load, but the significant improvement in the CSF dynamics, and including the size of the ventricles which have gone down. So this is the successful outcome of a fetal repair, which is evident immediately a few weeks after the surgery. So, and this is just one example I've thrown of. This is a case with a sacrocoaxial teratoma, which is again another indication that we do feel MRI. This diagnosis is obvious on ultrasound, but the reason we do MRI is to kind of characterize this, and one of the main things to look at here is if there is involvement of the spinal canal. So this is a detail which a fetal MRI can offer, rather than just doing that on ultrasound. So I just wanted to give you an overview of the most common indication that we do for brain is fetal ventriculomegaly, which features as a finding in not just malformations, even destructive lesions, complex genetic and post-infectious causes. I just show you a brief about the spine indication, the common spine indication that we get for fetal imaging. What do we have to look forward in the future for advanced fetal neuroimaging? There's literature. These are all still in the research realm of doing fetal DTI spectroscopy. And there's a lot of talk about artificial intelligence and automatically, particularly since we're talking about ventriculomegaly, for measuring the ventricles. But there are a lot of challenges because of the motion that is expected with these, but hopefully we will have kind of more on this in the future, where the artificial intelligence is particularly shown to be kind of more consistent in measurement than manual measurements, as well as functional MRI. So we'll have to wait to see how these advances pan out into the actual clinical imaging. And we'll end up by saying that fetal MRI is not for screening. It is useful in confirmation and characterization of CNS anomalies. It plays an important role in the decision making and how you counsel the parents, and also for planning the mode of delivery and after the kid is born, the perinatal care. And I want to acknowledge all the team, and the technologists who produce all these good images, and also teams of fetal medicine and surgery. And with that, I thank you for your attention.
Thank you, Dr. Karna. Indeed, it was a nice deliberation, and it was actually a visual treat to go through all the fetal CNS anomalies. And I specifically like that you highlighted the need to be sensitive and cannot be so particular about when you're predicting the neurodevelopmental outcome in a scenario, and you have to give a broad outlook at that point. So maybe the talk is now open, and we can have comments from all the other experts who have joined us. And maybe we can start with Dr. Lokesh Lingappa himself.
Yeah. Thank you, Dr. Kada, for that wonderful talk. It was good to know that you get the same information in US as we get in India. that one-liner saying that it's ventriculomegaly. And so I think the challenges for us is the amount of expert in the fetal radiology. They are very far and few. So even some of the biggest cities may not have a very good fetal radiologist. So they are improving in number, but I think still that's a challenge which we need to deal with as of now. And as you pointed out, the counseling part of it is to be very carefully taken because the whole of the family on both the sides will be involved. They're very anxious and they're expecting something good, and then they're trying to break in saying that it may not be as good. So those things have to be handled very tactfully. Thank you.
Thank you, Karuna. It's an excellent talk and very good pictures you have demonstrated. Now, what one big, one practical problem will be where to go for fetal MRI immediately or urgently, or what should be the clinical pointers to go for fetal MRI. Should it be guided by ultrasonic findings or some clinical pointers?
I would definitely say that, ultrasound findings are the first level, of where you pick up something, something is suspicious. I think that should be the basic first thing to guide you or to tell that, fetal MR is needed. And one of the things which is critical here in US because of all the changing rules for the timing of termination of pregnancy, it varies from state to state. In the state where I practice in Pennsylvania, it is about 26 weeks. So we usually, want to do this around in the 22 to 24 weeks of gestational age because earlier than 22 or 20 weeks, the study is not very good. The fetus is small and we get a lot of motion artifacts. So we try to do this between the 22 to 24 week gestation so that after the imaging is done, they can, the group can look at it and counsel the patient. So if there is anything, it's ultimately the decision of the parents. If they want to do a termination, they have a good window. So that is our kind of what you call the framework within which we need to do the fetal MRI, the urgency for the fetal MRI. And then if they come later, after 30 weeks, or if there is, plan to continue the pregnancy, I think the role of MRI and the counseling is just to prepare them for what lies ahead, and also to prepare for the mode of delivery and supportive care, depending on the case.
Yeah, so ultrasound is a very important pointer.
Definitely.
Dr. Karuna.
Oscar? Yeah.
Dr.
Yes,
Karuna,
I would be happy to hear anybody else's thoughts. Particularly, I think since in the US we are very much limited by the new domination rules in the states.
yeah, first of all, thank you very much for your excellent talk, very detailed talk. You said that as a definition, ventriculomegaly is the tip of iceberg, actually, but you deep dived into the part of the below the sea level. Actually, we learned many different aspects of the ventriculomegaly causes. You just give many good cases. Most of them actually straightforward. Those cases are some of the time not straightforward cases. We have to make follow-up. Many times we have to make a follow-up, especially with ultrasound. Sometimes as a second line MRI we have to do as well. In the past, in my country, as I know, most of the time the stakeholders were mostly the radiologists and the perinatologists. But in this panel, I have seen that the neurologists and the neurosurgeons are also involved. This will increase our diagnostic capabilities in the near future as well, in this fetal diagnosis area. even the genetics will very much highlight our diagnosis as well. The thing that I want to emphasize, until the preparation of the image, there are many steps which we have to deal as a radiologist. The success of those periods will increase the diagnostic quality, diagnostic success very much. Preparation of the patient, the mother, and the technical part, the technician is taking care, are very important parts in the diagnosis, because radiologists will define what radiologists see. If we have a good quality image with 3 millimeter thickness in at least three different anatomical planes, in each of them, 2 different sets all the time. If we get those, we will have good sources for diagnosis. And together with the ultrasonographic knowledge and cancellation of the findings, we will go to diagnosis by this way. But it's not easy. Again, I have to emphasize that some of the cases where the findings are not that much straightforward. We have to discuss if we have those kind of cases, we can discuss here as well. Thank you very much.
No, completely agree with you, sir, that, I have selected very straightforward cases to show and discuss. But majority of the times, or in real life, is basically you have to extract this information from very motion degraded studies, and I cannot emphasize how important preparation of the patient, the technique of the study is important. And another thing which I didn't actually tell is that every fetal case at our institute, we have 2 attendings read every single case, because of the high stakes that are involved, and you don't want to be kind of missing something because the potential impact is very high. So we have basically 2 attendings read or review every single fetal case, which helps a lot, because these are such sensitive things, and sometimes the images are not perfect and we don't have a clear answer. So we basically discuss it, whether, even the way you put it, the wording, like, if there is a high suspicion or low suspicion, it's very sensitive to the way you put it in the reports. And you have to be a little guarded, and every single case of fetal MR is unique, and they don't read the books. You can have multiple things going on, and it's, I think we probably, we just need to keep doing it. I think one thing we have established, I think even in India, when I trained, we did not have that many fetal MRIs. But now that I come, participating in all the meetings, I can see that a lot of, at least the bigger cities, it has become pretty established, and I see a lot of good work and being done. And based on the discussions I have or the cases that are shown, I think it has definitely progressed a lot. The use of fetal MRI and its acceptance as a part of the integral part of the workup in evaluation.
As an only take-home message, you already told, but just keep in mind, ventriculomegaly is not only finding of the measurement, actually. We have to very carefully look at the outline, as you told, the ventricle outline, for the possibility of the periventricular hypertrophy. We have to careful, both in ultrasound and MRI, we have to carefully look at that one. And the shape of ventricle as well. Karuna showed the cases of the myeloma cell cases. On that cases, we typically see triangular shaped morphology of the ventriculomegaly most of the time. It's a little findings, but very important. Shape is triangular. The ACC is the colpocephalic morphology. Even the shape of the ventricle gives sometimes views of the underlying pathology that we have to be very careful in decision-making point. Thank you.
Thank you, Dr. Karna. Actually, wanted to tell you that we in AOC in India, that's why we are making special interest groups. So this is a fetal neurology and neonatal neurology special interest group first time made because we think it is something very important. And you see, at one point of time, we had 200 plus attendees, and I think there is a lot of interest. I just wanted to ask you one before Dr. Indrani, I hand it over to you. You said that you have two attendees reading. Are they reading separately or together? And this discrepancy in how it's written, because we are establishing, and then we will, after Dr. Indani come to the two other experts from Delhi, we will tell about in IMS and in the private sector how they're doing. I mean, how do you do it? Like,
Yeah, thank you.
there is some iterator.
Yeah, no, we try to do it independently and then discuss it. We have one who's the primary reader, and for all like legal purposes, the report goes out in the name of only one radiologist. But we have a kind of a caveat that this was discussed with another person. That is how we do, and we the primary reader will trump. You know, if there's a disagreement, it will go in favor of what but it's always helpful to kind of just share your ideas or your concerns, you know, and it is good to get a vote of confidence if, you know, the other person agrees, or even if there's a disagreement, you know, that this is not straightforward. So I think it's very helpful to have another person, you know, review it because there can be some things which, you know, it's human error, you know, like certain things can be brought in together and then discussed. You basically come out with a better, you know, interpretation of what is there. And how I would be real curious to know what you guys do there in Delhi or in your institute or on this thing.
Yeah, we have colleagues experts. Dr. Indrani has something to say, and then we will have to from Delhi. Dr. Indrani, ma'am, please.
Thank you very much, Charlie. And thank you very much, Dr. Karuna. It's a good presentation. And actually, if you do a good extended neurosonography, especially by the endovaginal route in less than 24 weeks, recently in one of the international meeting in Ahmedabad, we presented our data. We get really good information, almost equivalent. Only in those cases where you have imaging difficulties, suboptimal because of the high BMI. I think more and more now I'm sending for MRI beyond 22, 24 weeks. And also, like in any developmental structures, there is a variation. Especially, I would like to know what has been your experience on posterior fossa lesions, like posterior fossa fluid collection, because lot of cases get referred as posterior fossa. Immediately, they are labeled as space cerebellum and Andy Walker and Wormis small. This the group of Wormis hypoplasia, Wormis small, and it's hard because I find MRI also gives same ambiguous results. So in fact, I've been using MRI for over 15 years now because the quality has become extraordinary, and also because it's gone to one person and we interact. So we go back on our pictures and then periodically we discuss where we had overcalled and undercalled, looking at the outcome, because we have a good pathology department. As much as possible, if we go for termination, I have asked them to give the fetus for pathological examination. And especially in this posterior fossa fluid collection, large big post is where MRI says the worms is small and it's lifted up because its angles I find are not of very great use at all. And looking at the fastidial point and the fissures, maybe, but then it takes time. This is a small one that is cerebellar worms that is growing. Because a couple of times I felt the worms is reasonably sized, but then after MRI, that hypoplasia or whatever those wordings, they pushed them and finally they went for termination. And I find it's just imperforate Blake's pouch. So some of these Blake pouches they perforate a little later. And in fact, I had one patient where second time also she had similar picture, but this time I was quite confident and I was took the patient into my confidence because I looked at the first almost up to 24, 25 weeks. So, good for the family that they had a favorable outcome. Posterior fossa cerebellar lesions you have not shown, and you sometimes get small hemorrhages that unilateral cerebellar hypoplasia, where the things are dictated depending upon the vermis, how much of vermis, how much of loss tissue is there. Could you just give your experience, because these are very crucial for counseling. As you said, we have a geneticist, we have pathologist, and then I have a pediatric neurologist also in the team. A couple of people have been pediatric neurologists. One's Dr. Ranjit.
No, I think it's the same. We are in the same boat. This entity. I was hoping to get away from posterior for some malformations, but there is no escape. I just showed like one Dandy Walker, which was like slam dunk case. But yeah, most of the times we get these cases, where depending on when you image them, what age of gestation that you image, and you get the same things. And sometimes the only thing I'll tell that we are now in a better understanding that Blake spout cyst, this entity, it is there, and we get a little more confidence in saying that yes, there's nothing wrong. This is more like a big spout cyst. When we do MR and we see that rest of the fissures and everything are fine. So even the way it is rotated, and details what we get on MR adds confidence. And I think we are better at telling that this is more likely to be a Blake cyst now after we do the MRI. And every case, we have a detailed ultrasound for this case, which get repeated even when they come here along with the MRI. And we always discuss those cases both, we have a weekly fetal meeting. Every case gets discussed with the ultrasound people and with the fetal medicine people and the neurologists at this stage, usually most of the times. And there are some cases which remain a dilemma. I don't think, there's no easy way out. It is most of the times then the prognosis is presented to the parents, and if they decide to continue, then the plan is to follow up. And we see many times, by the time they come to term, the worms looks nice. In the initial exam, it is difficult. You would think that it is hypoplastic, based on what criteria we use. But there is value for serial imaging, and there are certain entities when it becomes clear, but there is always going to be a big number of cases which are kind of on the margin, and we don't know how to deal with those cases. It's the same dilemma. I think the potential things are offered, and it's basically just making the choices left to kind of like the parents and the family. But we try to give as much information as we can based on the imaging. I mean, some cases it is good, we are getting greater confidence, but some cases, I would say like 50% of cases, there are these which are in the gray zone, and I don't think we are still in a position to be very confidently or dogmatically say, oh yes, this is this. It is still in that. We're still in that stage.
Thank you. It's really reassuring to me, because it's good to know that you also have the same issues.
Thank you. Indeed, a very valid issue. You always get stuck in conflict when you have a retractable space mass or when you have a ventricular hypoplasia. Maybe we can just switch over to Dr. Nitin with his experience when you have a posterior fossa anomaly. And what is your take, and how are we doing utilizing fetal imaging in our part of the world? Dr. Nitin.
So, Dr. Karuna, it was indeed an excellent presentation. You addressed several points, though everything cannot be covered in this period. But one thing which I wanted to add, as previous the other speakers have also mentioned about this, the biggest problem with fetal MR is the movement of the fetus, which affects the quality of the images at times. And at times, the most important thing is that after the ultrasound, there are a lot of expectations from fetal MRI. And at times we are not able to give same information, and even even the value addition is very minimal. So the movement is definitely a challenge. So we are doing fetal MRI for last many years now at Apollo Hospital in Delhi. So initially we used to struggle with movements significantly, but since last 4-5 years we have started giving maternal oral diazepam, that is 5 mg as the first dose, and if the movements continue, then another 5 mg, not more than 10 mg. So with diazepam, there are hardly any side effects we've seen in last so many years, and the image quality is little better. At least the images are not degraded to a level that we are not able to see the details in most of the T2 weighted images. With even weighted images, at times we do struggle, but the image quality is definitely better, and with oral diazepam, particularly if there are patients who are more keen that they don't want to take any medication, in those cases only we try to avoid any diazepam, otherwise it is a routine practice now at our center. And regarding the question of glaze pouch cyst versus vermi and hypoplasia, I do agree that these angles have a lot of overlaps. These measurements also have a lot of overlaps despite the correlation with the nomograph, but I've realized that the segmentation, so because we have done fetal MRI earlier 20 weeks also, so preferably 22 weeks is a good time, but even at 20 weeks if we see and make out the fast TGM is seen and primary feature is seen. So if we let's localize the key landmarks in the fetal vermis, so those landmarks are good assuring points that the vermis is likely to evolve nicely, irrespective of the angles and the measurements. Definitely, angles and measurements also matter, but if they are in the gray zone, then this localization of fastigium and primary feature at around 20-22 weeks is a good pointer that we can definitely wait and look for the vermis to evolve.
Sorry, I'm strictly against the use of any kind of the anesthetic during the scanning. It was in the past, it tried many years ago, but now, at least for the last 10 years to 15 years, I don't know any center that are using, maybe for certain cases, but in the routine practice, we never suggest to use anesthetic. For the posterior fossa, it's a very striking part actually, because it's small, because the fetus is small. The thing that I can suggest for this area, first of all, my suggestion, the diurnal pattern during the scanning in morning time. I strictly advise take your patient during the early morning time with the mother bladder empty, as the other corrections done. If the diagnosis is related with brain, before the big matrix, before the big image, big field of view image, just focus on your small image. I mean, if the pathology is in the posterior fossa, in the ultrasound, your first scanning has to be done with the posterior fossa. If the problem is corpus callosum, go directly image in 3 different plane corpus callosum. By this way, you will just visualize the critical area. By that way, you will gain time. We are just raising the time in this MRI scanning. For that reason, we have to first fish the questioned area under question, then the rest of the area has to be completed. I'm doing that way. Of course, the critical area, primary fissure, the fastigium, the tegmental angle, all has to be very clearly visualized. And you have to have your own databases for different gestational ages. Between 18 and 19, 10, 20, 21, those critical period. Knowing that the cerebellum is under development during the 20, 21, 22nd, there is we sometimes need to give the patient another second chance to make the final diagnosis before going to final diagnosis, we can maybe sometimes second ultrasound or second MRI, knowing that sometimes the tegmental angle is changing. We'll start with 40, and in the second we will get it 20 degrees. For that reason, before 23 weeks, I'm not talking very definite in some of the gray area diagnosis. My suggestion is that one. Thank you.
Yeah, I mean, good pointers, Oscar. And I mean, we don't give any sedation. I know that some places in Europe do that. I think we have our FDA limitations. We cannot use that. And I agree completely that, you have to go for the money shot sequences, focus on what is needed in the, in fetal image and try to the aim is always to try to extract. Sometimes we take the patient out if the mother's tired or agitated, calm her down, and then we'll bring her back. And we always scan our patients. They come at 7 a.m. or 7:30 a.m. is the typical time slot that we image them, and it's pretty good success because several patients they come from out of town, out of the country. They come the day before, and the first thing they come for is the MRI. Then they go for ultrasound, and most of them get counseled, the same day in the afternoon. What is to be done? So and follow up MR, we do follow up MR in some cases. Each case is different. We have insurance, approval issues, but there are several times where, particularly if there's a question of termination and if the scan is done like 19 weeks or 20 weeks, we'll do another one at 24 weeks. And they all get a follow-up ultrasound. There's no question of that. In cases of these borderline, they will get follow-up ultrasound, and in some cases even follow-up MR.
During the exam, you can let the husband go together with mom. It decreases the stress of the mom. It's you will feel if you try like that. If he just hold her hand, decrease the claustrophobia, everything will be better.
Yeah, anything to make the patient comfortable. Yeah.
Thank you. We'll ask Dr. Smita to briefly make her comments. And one thing I want to say, we actually started 10 minutes late, so apologies for that because of technical issues. And actually, we had the talk between 8 and 9, and then 9 to 9:30, we were supposed to have 5 cases with 5-minute presentation and 2-minute discussion. So I think Dr. Smita's comments, and then we will have the cases. I'm requesting presenters at 5, you will have to stop, So because you all are prepared, so we will go on. So we should, after 5, then keeping 2 minutes for discussions. So, Dr. Smita, your comments, please. And Dr. Arun, I would request that there are 2-3 questions if you could answer directly in the Q&A box for want of time. And Dr. Smita, yeah, thanks.
Thank you, Dr. Karuna. That was an awesome presentation of cases with the NNI spectrum covered. So as far as how we are doing about it at AIMS is that most of the times as a referral is from the ultrasound, so usually we are doing the scan after 22 weeks. And the current guidelines in India for the MTP is 24 weeks, after which a medical board is formed. So in those cases, most of the times we are doing multidisciplinary approach with an obstetrician, a pediatric radiologist, a pediatric neuroradiologist, pediatric neurologist, and a neurosurgeon in some cases. There's and a genetist on board so that consensus decision is obtained and the patient is counseled accordingly for the termination of pregnancy or the continuation of pregnancy with the findings which are there on the fetal MR. And as Dr. Indrani ma'am was suggesting that sometimes even we go in for a re-look ultrasound after the MR, so that also happens. And then there is definitely the role of the interdisciplinary approach in terms of the how we are going about in reporting. Here also we are doing 2 people, and especially in the complicated cases where there is a crucial decision between termination and continuation, in those we are even taking the pediatric neuroradiologist on board, like Dr. Then we consult most of the times because the counseling then becomes very important for the patient. So there's a one primary person who's reporting and then another secondary person who is independently seeing the case, and then many times the consensus is obtained where the final decision is definitely with consensus, but the senior person is with more experience is finally taking the day. And yes, interdisciplinary approach for most of the cases where counseling of the termination versus continuation is advised.
Thank you, Dr. Smita. So, quickly moving to the case presentations, do we have the first presenter ready?
Yes, sir.
Can you please start your presentation?
Sure.
Thank you. So this is a case from Dr. Mukesh Singapur's Hospital, Rainbow Children Hospital, Hyderabad. Over to you, Dr. Cooper.
So this is a case of fetal ventriculomegaly. This is a case in 2018. The 26-year-old female, she was Bragda 1. She came to us in 22nd, 23rd week of gestation. During that time, in the ultrasound, there was mild ventriculomegaly. The lateral ventricular diameter of the was 11-12 mm, and then fetal head biometry was done, which showed normal patterns. So then we went ahead with the neurosonographic findings. As you can see in this ultrasound, there were nodular irregular ventricular margins, which were nodular. Hypoid lesions were seen with poor definition and normal morphology of the cortical sulci. Then the fetal MRI was done, and the fetal MRI also in the actual view, as compared to the normal, there are in the frontal region, there are nodular hypointensity which is seen in the T2 scan, and there is an abnormal sulcation which is seen. Also, the cerebral parenchyma, it looks like there is a loss of multi-lead, 5-lead pattern which is expected at this gestational age. In this coronal section also, similar hypo-intense lesions along the ventricular margins are seen in the frontal horn, and they are dilated, and there is a dysmorphic frontal horn which is seen. And similar to this sagittal plane also, we can see the similar frontal hypointensities. Based on these findings on the fetal head ultrasound and then followed by the MRI, the fetus was suggestive of malformation of cortical development, likely lyssencephaly associated with Miller-Dieter syndrome. After this, the parents or the prenatal counseling of the parents and family was done, and genetic test was advised, but parents were not willing. And then finally, the fetus was advised for termination. Following termination, the autopsy was done, which was suggestive of cortical rim abnormalities and other features that were corroborated with the MRI findings. So in the lysencephaly spectrum, in these cases, less than 20 weeks, usually there are 3 layers, as you can see in this pictorial representation. And by after 20 to 28 weeks, we expect a 5-layer pattern as shown, which was clearly missing in our case. Also, the other common findings that are found in lysencephaly are eGaia, normal serine tissue, ventriculomegaly, corpus callosum dysgenesis, microcephaly, intrauterine growth restriction, hydramnios, and the different genes which are associated with lysencephaly, as can be seen, and the LIS gene and Bellin gene and tubulopathies and X-linked ARX gene can also be associated. Already ventriculomegaly has been covered, but the most common causes are obstructive, abnormal cerebral development, and disruptive causes. Unilateral ventriculomegaly is more commonly obstructive, whereas the developmental anomaly ones are mostly bilateral. Ultrasound can be limiting in some anomalies in case of migration defects in hemorrhage and parenchymal damage. And excellent tissue contrastive MRI and absence of bone interference makes MRI a good technique for cortical evaluation. So the take-home message from this case was that lateral ventriculomegaly, it is the tip of an iceberg in case of a fetal CNS imaging, but it is a very sensitive marker for detection of a variety of fetal CNS malformations. The cortical malformations are challenging because of the heterogeneity that occur according to the gestational age. and due to technical limitations and relative lack of diagnostic specificity, the fetal ultrasound might miss important findings. So, fetal MRI is a good diagnostic modality that helps in detection of additional abnormalities like illness of corpus callosum, disorders of cortical development, and cerebrovascular abnormalities.
Thank you, Dr. Purva. Can we have a quick comment from Dr. Lokesh?
Yeah, I think that's already discussed extensively. Ventriculomegaly can be just a telltale sign of something significant underlying, and following them up and extensively evaluating to make sure it's isolated. Mild ventriculomegaly, no associated cortical abnormalities, brainstem abnormalities, and other systemic abnormalities, then we will be able to counsel them in a reassuring manner. If otherwise, I think as Dr. Karna already pointed out, we should be very careful and cautious and explain all the difficulties. Thank you.
Thank you, sir. So, can we move to the second case and club all the expert opinions maybe after we have finished 2 or 3 cases? Dr. Pooja, are you there?
Yes, sir. Good evening all. I'll be presenting next case for today's presentation, which is case of an antenatal diagnostic dilemma. So this case is of a 30-year-old female who gravida 5 paravan.
Share your slide. Bhushan, your screen is not sharing.
Share your slide.
Is my screen visible, sir?
Yes, full screen here.
Full screen. Make it full screen.
Yes, sir.
Yes.
This case is of a 30-year-old female gravida 5 paravan live one with 3 abortions who presented to us at 29 plus 4 weeks period of gestation with abnormalities in antenatal ultrasound suggestive of significant intracranial lesion with the possibility of teratoma. She had her first pregnancy 7 years back, which resulted in birth of a normal full-term baby, and her second, third, and fourth pregnancies resulted in spontaneous abortions in first trimester. This is her fifth and current pregnancy, which was a result of spontaneous conception. In her first trimester, she was prescribed aspirin and progesterone in the recurrent pregnancy losses, and there were no other abnormalities. In second trimester, she had quickening. At 5th month period of gestation, level 2 scan was normal, and she was continued on aspirin and progesterone. In third trimester, she was perceiving normal fetal movements. There was no history of polyhydramnios or bleeding from any other side, but she presented was with abnormalities in antenatal ultrasound, suggestive of cystic lesion. For recurrent pregnancy losses, she was evaluated, and her hemogram and clinical biochemistry profile was normal. APGAR workup was negative. Coagulation profile, torch profile, and homocysteine levels were in normal range. So this is the antenatal ultrasound, which is suggestive of a cystic lesion with areas of calcification and echogenicity, with the possibility of teratoma and intracranial hematoma. But the diagnostic clarity was not there. So to clarify the diagnosis, since it is important to clarify as the prognosis of teratoma and antenatal hematoma are different, teratoma carries a grim prognosis as less than 10% cases of teratoma are known to survive. And literature has suggested that cases of teratoma succumb in view of cardiac compromise secondary to high output cardiac failure or in view of hydrocephalus. On the other hand, antenatal hematomas are known to have variable prognosis, ranging from dismal prognosis in form of stillbirth to better prognosis in form of developmental delay, focal deficit, and seizures. So, to clarify this diagnostic dilemma, we planned further investigation, including fetal MRI and antenatal Doppler. In this fetal MRI, we could see that there is large extra-axial lesion, which is hyperintense with interhemispheric fissure extension and along with presence of pial venous abnormalities. So this was suggestive of possibility of hematoma, and it made the possibility of tumor less likely. To clarify further, we went ahead with Doppler.
Here we could see that there is cystic lesion with both echogenic and hypoechoic areas with midline shift and smooth margin, and on Doppler there was no evidence of vascularity. This further reduced the possibility of teratoma, as teratomas are known to have high vascularity and irregular margins. So, considering the possibility of hematoma more likely, parents were concerned regarding the future risk of neurodevelopmental deficit, and pregnancy was continued till term. Baby was delivered with elective LCS at 40 plus 2 weeks of gestation with normal abcars and had normal width and head circumference at birth. And on examination, baby had normal anterior fontanelle with good state-to-state variability, no cranial nerve deficits, no papilledema, and motor examination was normal. To evaluate further the possibilities for underlying etiology, maternal and neonatal phagocytopenia was ruled out. Thrombocytopenia and neonatal alloimmune thrombocytopenias were also ruled out. So baby was conservatively managed as he did not have any signs of raised ICP, and postnatal MRI was done at 8 days of life. Here in this sagittal T1 section, we can see this concave convex subdural collection along the right frontoparietal region with extension into interhemispheric fissures. Also, there is calcification along the periphery and midline shift of around 7 mm, which was suggestive of possibility of hematoma. On SWI, there was blooming as well, which confirmed our diagnosis of subdural hematoma, and the possibility of teratoma was ruled out. So baby was conservatively managed with regular monitoring of head circumference and sensorium, and there were no signs of raised ICP. So the baby did not require any neurosurgical intervention. Further, baby was monitored, and on day 12 of life, baby developed left focal seizures, for which the possibility of a fresh bleed was considered and NCCT was done to rule out the bleed. And on further follow-up at around 1 year of age, baby had normal developmental milestones with mild left hemiparesis and occasional left focal seizures, for which he was continued on oxcarbamazepine. So at 1 year of age, follow-up MRI was done, which was suggestive of cystic encephalomalacia in right frontoparietal region, and some possibility of dural AV fistulas. So at 6 years of age, currently the child is at 6 years of age, developmentally normal, is not having focal deficit and is seizure free and is currently off anti-seizure medication. So this child fared well, better than what we had expected. So in this case, we would like to highlight the possibility of fetal MRI as a good complementary tool for better prognostication and delineation of lesions. A word about fetal intracranial hemorrhages. In a study then which showed 86.7% of the cases of intracranial hemorrhages present in third trimester, and out of this 64% are bilateral. And MRI is very instrumental in confirming the severity and location of the intracranial hemorrhages. Out of these cases, 42% resulted in termination of pregnancy, 7% had intrauterine fetal death, and 50% were born alive. Out of those who were born alive, 71% had only mild to moderate motor sequelae. Thank you.
Thank you, Dr. Puja. So, I don't have to add much to what just presented, and maybe we can quickly move on to the experts. They comment on these two cases, and let's be brief so that we can cover all the 5 cases that we want to. Dr. Karuna, Dr. Oscar, Dr. Nathan, Dr. Smita, if you have you.
I just want to ask if there are any changes in the underlying brain parenchyma on fetal MRI on T2 or on diffusion to decide during that when the bleed was in the extra-axial space where the underlying brain was showing changes in the signal.
So actually, I had reviewed the previous MR. It was of 2017. So the films the patient was carrying did not have any T1 or diffusion-weighted imaging. There were 2 sections like axial and caudal of the T2-weighted image. In that, there was a marked midline shift and significant compression of the underlying brain parenchyma on the right side, which showed mild increase in the periventricular signal intensity. But the main thing was that there was a very large hematoma which was like entirely T2 hypointense, extraaxial in location, with extension along the interhemispheric fissure. So when we again saw the follow-up CT and MR of this child from 1 year of age and then at I think 6 years of age, that by 6 years the ankylomalacia pages had set in, but at 1 year of age also there was predominantly that large bleed along with a probably a wire AVF, which was there was a dilated venous channel which was extending from that right frontal location near the central sulcus to the superior sagittal sinus.
actually the amount of bleed was quite significant, which would
very
definitely
desperate.
suggest that the prognosis is not likely to be very good. But in this case, proved to be contrary.
Because ultrasound was very much like the films that patient was carrying. It was looking like teratoma. There were areas which were very echogenic, and there were some areas of mixed echogenicity. But it was very extra-axial even on those films, ultrasound films. But the MR was very characteristic that yes, it was a hematoma and not like a tumor. So I guess that is why the patient continued.
Actually, when the images started being shown for that case, I was actually wondering if they're non-ocular dural sinus malformations. That was my thought, because those are less likely to have parenchymal changes. I mean, good outcome with if parenchymal changes are there. Yeah, and I think for the first case, the extent of nodularity was pretty high on the vertical margins. And I think one should think of FLNA or some other mutations in that case. Yeah, I know that we are not the best
Mansi,
in
can you
diagnosing
mute the others? Mansi, mute others. Mute others. Only, yeah. Sorry, Dr. Aruna, please.
Yeah. No, I think we are not really that good on cortical malformations or subtle changes in the fetal MR. Many times we have to rely on the postnatal workup to come for a diagnosis. The first case, there was very extensive nodularity along the entire ventral margin, so FLNA mutation would have been one thought for that.
One thing,
But good workup and good follow-up on both cases, to comment on that.
for
One thing was a fetal medicine expert who was looking first case along with Dr. Lokesh. So, if you want to comment on what Dr. Karuna suggested, it was a workaround for preventable heterotopias.
No, actually, good evening all. Thank you so much. In this case, at 22 to 23 weeks, here the pattern of abnormality was striking with respect to periventricular nodular heterotopia on ultrasound itself. What MR added was the marked delay in the cortical sulcation. The Sylvian fissures were absolutely shallow. The crito-occipital fissures were not seen. So this was classic appearance in addition to periventricular nodular heterotopias. So I was not very sure of isolated FLNM mutation here. So here, with respect to counseling, it is like traffic red signaling, red light, yellow or green. Here definitely it was like red light, and we asked for an amniocentesis, but the patient deferred and underwent termination. And in autopsy report, the lining said cortical layer irregularity and suggestive of malformation of cortical disorder. This was the only line which I remember which I read, because after the autopsy, the patient got the reports. So actually, genetic analysis would have helped whether it is isolated femin or there is an associated novel mutations, because we really don't know exactly what the amnio results were.
Sir, you were saying something. Yeah. For the second case, actually, if you compare cases with the Karuna showed one cases in the posterior area, just the supersagital sinus area, there was sinus malformation. The color, the signal intensity is very similar to that one in different area. That's the reason I was also thinking something related to the sciences. And in the ultrasonographic definition, she told that there is a classification, something like that, if I didn't misunderstand. Classification, sometimes in neurosis malformation, even in the cases of the posterior case, supersagittal cyst case, Karuna showed, if we go through with ultrasound, we may find some calcific area thrombosis inside the neurosinus area as well, which also helps the diagnosis of neurosinus malformation in that case. Classification is not the classification related with the teratoma. Classification was the clue for diagnosis of neurosinus kind of malformation for the second case. It was actually excellent case actually. For the third case,
I agree. There is a parental notority which is very clear on the ultrasound and support with the findings of the MRI. And additionally, cortical shallow morphology, which is in one of the spectrum of leukoencephaly. The flamin-related genes could be suspected in the diagnosis in combination of periventricular nodal retinopathy and spectrum of leukoencephaly. I was just thinking of the spectrum of the flamin-related gene as well as a causative agent. Both are very, very good cases actually. Thank you.
Dr. Lokesh, Dr. Lokesh and Dr. Vivek, anything? Dr. Vivek Alwar, Dr. Lokesh, anything you want to say, please? Very briefly.
Observing the ultrasound gives some finding. Then you go for MRI for better imaging or better finding. In both cases, now you see it appears every ultrasound is going to be predicted by MRI. Do we need some clarity in policy? Practically every ultrasound in practice will be predicted by MRI. We probably need further studies, observations to verify what are the clear indications where MRI versus ultrasound.
Many a times when you are prognosticating such fetuses or such families, so even though with one investigation you might be quite clear, but as a pediatric neurologist or maybe a pediatric medicine expert, you at times would want two different modalities to actually say the same thing. So it gives you more confidence because this is a very sensitive issue. So there is why many a times if there is an anomaly which needs characterization, that is why we thought, okay, we'll also see what the doctor is going to tell us, what the fetal image MRI is going to tell us, so that we are very composite. So if that, they say that if you do a proper neurosonogram to the transvaginal approach, you might be able to give a clear answer. But if you have another modality which gives yourself a second finding, then you are very comfortable in giving up the prognosis. So that is why in many situations go ahead and do that.
One more thing I want to add here is whenever there is a fetal MRI referral, the patient is already carrying 3-4 ultrasound reports with them. Different centers, different doctors. So actually, beyond the point, it becomes difficult for ultrasound to characterize because there is an inherent limitation of the modality itself. So better to switch to a different modality at an early stage to get an additional perspective. So that should be the message. If ultrasound can give a very good, more or less authentic diagnosis, and where even if you go for an MRI, it may not add much. Maybe you can go ahead with ultrasound because ultrasound has the advantage of you can repeat it as many times as you need. So time will tell us.
Let's quickly move to the third case. Dr. Rakesh. This case is from Mamita Kochi and the moderator is Dr. Vaishakanan.
Hello everyone. Addressing a case is on antenatal detected corpus callosal agencies, a follow-up study. So corpus callosal agencies is the most common brain malformation seen worldwide. It is seen in one in 4,000 live births. And it is common accompaniment in 3 to 5% of neurodevelopmental disorders. And outcomes unclear in isolated agencies of corpus callosum, as the outcome can vary from normal, completely normal, to severe developmental delay. So in our group, we had 8 patients who were followed up for a period of 5 years, who came with an antenatal diagnosis of corpus callosal agenesis. So in our group, 7 months was the youngest kid, and the eldest one was 5 years of age. So coming to the age distribution, we had 3 kids who were less than 1 year, 3 kids were 1 to 3 years age group and 2 were more than 3 years. Coming to the gender distribution, we had 6 of them were males, which constituted 75%, and 2 of them were females, which was 25%. And coming to the antenatal diagnosis, 5 of them had an antenatal diagnosis at second trimester, and 1 of them came with a first trimester ultrasound saying that corpus callosum was not visualized, and in the subsequent second trimester ultrasound it was seen. And 2 of them had a third trimester ultrasound which detected corpus callosum agenesis. Out of the 2 who were detected in the third trimester, 1 of them had a second trimester ultrasound which had missed the second trimester corpus callosum agenesis, and the patient was referred to our center. Usually, the sonograph visualization of corpus callosum is made at 18 to 20 weeks, and the final shape is usually visible by 20 weeks of ultrasound. So then, seeing the follow-up, none of our patients had luckily had epilepsy on follow-up so far. Coming to the developmental status, 2 of the kids had developmental delay, global developmental delay, and 1 of them which had associated hearing loss also. And the significant developmental delay seen in these 2 kids who also had associated dysmorphism and other systemic involvement. So probably extracerebral involvement has a positive predictive value for developmental delay in children with corpus callosum agenesis. And coming to behavioral symptoms, 1 of these kids had a hyperactivity and aggression. He also had decreased sleep. This kid is the same one who had dysmorphic features as well as other system involvement. And family history, 1 of the kid had a history of epilepsy in his cousin and a history of febrile seizure in his paternal aunt, but he did not have seizures so far. Coming to other system involvement, 1 of the kids had a significant pulmonary stenosis, and the other kid had a hypogonadotropic hypogonadism. These 2 kids also had associated craniofacial dysmorphism. So the craniofacial dysmorphism these in these kids were the case 3, there was associated microcephalian left-sided ptosis, and case 6, there was microcephalian retrognathia. Coming to VEP, 2 of the kids had a normal VEP, and coming to BERA, 1 of the kids had a normal BERA on one side. And coming to EEG, only 1 kid had a mild abnormality in EEG, that is this one. All others had a normal EEG. And coming to brain imaging, there's 6, 7 of the kids had a MRI brain, and 1 of them had a CT brain. All of them had a complete corpus callosum agenesis, and in addition to that, 3 kids had other findings. 1 had an intrahemispheric hemisphericist, 1 had a right olfactory bulb agenesis, and the third one had a midline lipoma. And coming to the pattern of corpus callosum agenesis involvement, 7 out of 8 had a complete agenesis of corpus callosum, and partial agenesis was seen in none of the patients, and 1 of them was found to be normal, who came with antenatal where corpus callosum was absent. 1 had a normal MRI in postnatal period. So these were the additional findings from MRI brain, interhemispheric 6, olfactory bulb agenesis, and midline lipoma. So these were the first 2 were MRI, and the third one is the CT scan. The second one is showing a midline cyst, interhemispheric cyst. Coming to genetic test, microarray was done for 3 of the patients. Out of the 3, 2 had a negative microarray. And 1 of the patients had a duplication of XP2213 and duplication of CDKL5. But this, on literature searching, it was not found to be associated with corpus callosum agenesis. And the female children in our group did not have features of Aicardi syndrome. That is, chorioretinal acne and seizures were not there present in them. So coming to the discussion part, gender study at our group had 75% males and 25% females, which was similar to the other studies published, 78 and 28. And other CNS involvement was present in 42% of our patients. It is also similar to the published study in international literature, which is 21 to 93%. And systemic involvement, that is, other system involvement was seen in 25% of the patients, and it was also similar to the internationally published literature, which is 21%. And epileptic seizures, however, were not present in our group, which was 23 to 39% in the international literature. And genetic positive cases, that is, by microarray, was 12.5% of our patients, that is, in one case, and it was 9% in the published literature. In the agenesis pattern, we had a complete agenesis in all the cases, which was only 54% 0.5% in the published literature. And developmental delay they had 28.5% of the patient, and the published literature was similar, that is 27%. So the take-home messages are isolated corpuscular surgeries overall has a good prognosis, and prognostication will depend upon the presence of other cerebral malformations as well as other systemic involvement and associated syndromic and genetic involvement. It is prudent to screen for other brain malformations in the antenatal as well as postnatal period and for other associated extracranial malformations. So these are my references. Thank you.
Thank you, Dr. Rajesh, for this small case series of CCHS. So, can we have a quick comment from Dr. Vinay sir and Dr. Vishal?
Thank you, Dr. Rajesh, for summarizing the case series concisely. So, with the advancement of antenatal diagnostic, we are detecting more and more subtle anomalies. And CCS is most commonly, it's the most common anomaly nowadays we are detecting. So, as pediatric neurologists, most often we are called to counsel the parent or the family regarding the implications of this antenatal CCHS, and it's not an easy job. So, what our cohort found was corroborating with the previous studies also, where we found that almost two-thirds are having normal development, although the follow-up is not that great. It's the maximum follow-up was 5 years only, but till then, only two-thirds had normal development, and another point that we found in our study was that when extracerebral malformations of dysmorphism are present, that the chances of getting a development delay in the follow-up is high. So, another interesting feature that I found in our cohort was that 75% were males. And surprisingly, previous cases from outside India also was mentioning the same. The reasons, I don't know. And so, we can wait for the experts' comments on this. Yeah, your is all of them has just very hard. I think it's honest. We find it so one not as a thing as a purpose, as it's serious are very common in some that's actually develop it which is just in all of the in my observation it is interesting. There's no
Use the shorts.
yeah.
It is quite heterogeneous, the outcome, it is radiologically isolated, but what is the genetic underpinning? So, sometimes you see just CCHNS and later on they would gradually have some degeneration, may have PCH, pontocerebral hypoplasia later on. So these issues are there. So I find sometimes CCHNS as having a more variable sort of an outcome when you compare to say an isolated ventriculomegaly. So that is there, but yes, you through your cases you can see that the outcome is pretty much okay. But many times, because the nature of this anomaly, you might have some learning disabilities that are there in these kids. So this evaluation, postnatal evaluation, needs to be very detailed, to pick up these learning disability and subtle deficits in executive function. So thank you, Vishal.
Actually, Prashant, as what you have said very rightly, it's a very heterogeneous group, and if you see in Swimmer, there's a huge big table for corpus callosum agenesis. So that is why the outcomes different and variable, right?
True, man, right. So should we move to the next case and then again we can couple up with the discussions?
Just some point to add here regarding the corpus callosum agenesis on fetal MRI. There is a recent publication from Austrian group. Austria, University of Vienna is a place where they are doing the fetal MRI case, and they have a publication particularly addressing to the corpus callosum agenesis. So based on the fetal MRI, once it is diagnosed at around 20 to 21 weeks, there is a 7-point scoring system where you look at the other structures because we already know that corpus callosum is not there. Then based on the morphological development of the brain, including the lamination, telencephalic lamination, sulcation, basal ganglia status, ventricular dimensions, and 4-5 additional points, there is we can predict how nicely what to the prognosis. So based on that fetal MRI scoring system, there is a possibility to predict, according to that score from Kasurian and group, the score is more than 4 or more than 4, then the prognosis is bad. Otherwise, the prognosis can be good in these cases with corpuscular imagenesis. So this is something which can
you're talking about.
evolve. Yeah.
Your voice is more better.
This is a very nice thing you have picked up, you have spoken about here. Now, what are the number of cases on the basis of which the graduate prepared, the scoring system was prepared? What is the number of cases? So I have to review that article again, but it was a recent article only which can be a very good beginning towards this direction, because otherwise, as you just mentioned, the prognosis is very variable. So once you label it corpus genesis, then prognosis can be right from good to bad. So we have to subdivide this wide group into different areas so that we know this is good and this is not very good. Yeah, it is okay. Only thing is that if the numbers are very small on the basis of which each scoring system has been found out, later on it may not become very meaningful. It may not always be that confirmatory or so. We need larger number of cases whenever one tries to establish a scoring system. I need look at that literature. I think this is my
That it is applicable to our geographical area, other type of genetic factors, and maybe acquired knowledge.
Prashant, can we have the next 2 cases and then final discussion? Because we already to it 38
We
minutes.
have next presenter.
Neha, make it full screen, please, fast, please.
Yes, ma'am. Good evening, everybody. I'm Dr. Neha, and I would like to thank Dr. Indrani and Dr. Ranjit. I will be presenting a case of prenatal diagnosis of dural venous sinus malformation. So she was a 37-year-old, gravida 2, abortion 1, married since 10 years. She was referred to us for second opinion for a cyst seen behind the lateral ventricles, pushing the midline. So she was IVF pregnancy. There was no significant medical history. Her first trimester screening was negative, and she presented to us at 21 weeks 3 days. The growth, liger, and activity was normal. On doing an extensive neurosonogram, we found that there is a hypoechoic lesion seen in the supratentorial region, which is triangular in shape and it is avascular. So it is measuring around 1.6 to 2.1 centimeters. So these are the videos and the images for the same. We can see that this is in the posterior fossa, supratentorial hypoechoic lesion. And on color flow mapping, there was no vascularity. So we have given a diagnosis of dural venous sinus malformation, and we had advised a fetal MRI at Sri Ram Institute of Medical Sciences to confirm the diagnosis and to look for additional malformations on MRI. So the MRI was done at 22 weeks of gestation. On the axial section of the MRI, these are normal pictures of the MRI on T2 weighted imaging. We can see that there is a hypointense lesion in the posterior cranial fossa, which is indenting the right side of the cerebral hemisphere and the right occipital lobe. There was a dilatation of the right transverse sinus. And on the sagittal imaging of the MRI, we can see that there is dilatation of the posterior end of the superior sagittal sinus and the auricula. So the lesion was measuring 2.5 cross 2.8 cross 1.4 centimeters. So the diagnosis was given in favor of dural venous sinus malformation involving the posterior end of the superior sagittal sinus, the auricula, the right transverse sinus with partial thrombosis.
So from this information, we had counseled the patient that in most prenatally diagnosed dural venous sinus malformation, there is no predisposing conditions, and the venous thrombus occurs as a result of maldevelopment of the sinus. The thrombus may remain static or may regress in the course of pregnancy, but the neurological deficit, if present, can only be ascertained postnatally. The MRI findings confirmed the ultrasound findings, and additionally, the extent of the venous thrombus was mapped and finding of partial thrombosis was reported. So we had advised the couple for frequent follow-up. The couple came for follow-up at 24 weeks, 28 weeks, and 34 weeks for us for scanning, on which we noted that the dural venous sinus malformation had regressed in size, and the clot area as well as the cystic area had regressed. And by 34 weeks, the lesion could not be made out of the scan. So the outcome was it was a full-term cesarean section at 37 weeks, 3 days due to breech presentation. It was a male child, 3.5 kg. Baby cried well at birth. The APGAR score was 8 and 9. MRI was done on day 3 of life, which reported a prominent torcular right transverse sinus and a prominent sigmoid sinus with a small thrombus in the torcular. Developmental follow-up with pediatric neurologist was advised, and the child is now on yearly follow-up. Baby is now 4 years and doing well. All the milestones are good. So just enumerating the data of Mediscan over the past 23 years, we have seen 12 cases of dural venous sinus malformation. The mean gestational age at diagnosis was 23 weeks, 4 days. And the most common site of dural venous sinus malformation were torcular herophili and superior sagittal sinus. The size of the lesion at presentation ranged from 1.6 centimeters to 4.4 centimeters. Out of the 12 cases, MRI was done in 6 cases. These 12 cases, 5 cases had followed up with us, in which 3 had regression, 1 remained static, and 1 increased in size. Out of the total 12 cases, however, 10 opted for of pregnancy. 1 had a neonatal demise in which there was in association of arteriovenous fistula and there was cardiac failure. Baby died on day 1 of life. And 1 child is doing well, the case that I presented. So the natural history of a dural venous sinus malformation is that the size may regress either prenatally or postnatally. The size may increase in few cases, and the size may remain static as well. There might be development of ventriculomegaly, or there could be mass effect on the brain parenchyma. There might be hemodynamic changes, which is not so commonly seen, only if there is a arteriovenous fistula present. So the take-home message from this case is that dural venous sinus malformation is mostly an isolated finding. Presence of a supratentorial cystic lesion should prompt to look for differential diagnosis of dural venous thrombus. The outcome depends on the size of the thrombus at presentation, association of ventriculomegaly, mass effect on the brain parenchyma, and regression of the lesion as the gestation advances. So the diagnosis of dural venous sinus malformation is not an automatic indication for termination of pregnancy. Thank you.
Thank you for the nice case and the nice message that you come up. So can we have a quick comment from the faculties?
Yeah.
Dr. Ranjit, Dr. Ranjani.
Thanks, Neha, for presenting this nice case. Just to highlight that the progressive regression of the lesion, isolated anomaly, absence of fetal decompensation, absence of any cardiac failure, all pointed towards a good prognosis in this case. I just want to emphasize the role of pediatric neurologists in fetal neurology counseling. So, if Dr. Indrani is there, want to add any comments from
Thank you, Neha. That was a good presentation. The important point is even in one case where it was regressing, because of uncertainties, people read a lot of literature now, and then that is how one case is actually becoming less, they opted for termination. This particular family, they had there was no options because it IVF conceived and there was no embryos left, and also had some issues on the husband had malignancy treated. So after at least 3 or 4 sessions of back and forth counseling, they agreed. And today, the mother, when we called, she was extremely thankful and she thanked the whole unit. So the potentials are there when the lesion is becoming less and the brain parenchyma is going well. I think we have to give them the guidance in a proper way, even though we say it is a non-directive counseling. Thank you.
Thank you, ma'am. Thank you. Can we have the last case and then we can have a couple of comments from all the experts? Dr. Dasrata, are you there?
Yes, sir. Dr. Sumshir will present, sir, my neonatology fellow. He is sharing the screen. Yeah.
Sure.
Good evening, all. So I am presenting a sudden unexplained neonatal death, the unusual cause. So this is a full-term normal vaginal delivery female baby had 36 hours of life. It was found unresponsive in the postnatal ward. So when the consultant reached the postnatal ward, so there was no signs of life. So we have done the resuscitation, but baby couldn't be revived. So we labeled it as sudden infant death syndrome. So the possible causes we have explained to the parents was like aspiration. So on postmortem evaluation, we have done postmortem evaluation. So we probed into the family history. So we showed there was a consanguineous couple and there was one first trimester abortion, spontaneous, and one neonatal death within 34 hours of life. This is the current child. So on examination, there was some facial dysmorphism in the form of depressive nasal bridge, white nasal bridge with thin lips, long philtrum, and retronath also. So the differential diagnosis was like metabolic cause and genetic epileptic encephalopathy and long QT symptoms. So for that we have sent WS, which was found ALD7A1 homozygous mutation, which was pathogenic. So we have again tested the parents with the WS. So both parents were carriers for the same mutations. So this is one unexplained neonatal death. So when we have labeled as sudden and unexplained neonatal death with virus independent epilepsy. So when we reviewed the literature, we couldn't find any case reports with sudden unexplained neonatal deaths. So next pregnancy, the antenatal genetic testing was done. So again, it shows similar mutation in the fetus. So we have counseled the parents regarding the prognosis and explained for termination of pregnancy, but the parents didn't opt it, so they want to continue the pregnancy. So we have started the mother with the pyridoxine 100 mg and the mother delivered normal vaginal delivery. The baby was admitted to NICU. We have started an oxytocin injection and calcium folate injection. So we have done a cardiac echo, blood gas was normal. So urine GCMS was normal. We have sent the plasma amino acids, which the report is white. So this is the main pathogenesis of this pyridoxine dependent epilepsy. So we have started on folic acid because genetic mutation is similar to this pyridoxine dependent epilepsy. So after 48 hours, we have started on lysine restricted diet along with the mother feeds. So the baby, this is the present a normal baby having the same dysmorphism
like depressed nasal bridge and broad nasal bridge. Um, so when we review the literature, so there is a facial dysmorphism in the form of depressed nasal bridge, epicondyle folds, and broad nasal root. This is the reference for it. So we have discharged the baby on 7 days of life with oral pyridoxine and folic acid, lysine restricted diet. Now the baby's age is 4 weeks, doing well. So this is the doses of pyridoxine at different ages.
Thank you.
So we have similar two scenarios in the postnatal ward. So for which we have sent the BS. So both children, one child had LCAT deficiency and one more child had carnitine acyl organ translocase deficiency. So here the clues are like Alzheimer's marriage and maternal acute fatty liver disease. So for other case, the clue is consanguinity and issue of early neonatal death.
Yeah, it's a good case.
I see.
Good case. One more reason to, pyridoxine deficiency.
Yeah, this case highlighted us what
Sudden death.
we don't know. So this is another
Likely to be.
new phenotype for seeds, and even we are explaining the possible catastrophic outcome in the present pregnancy. The parents took a decision to continue, and that also gave us an opportunity to explore more about this condition. Now we are feeling so happy that baby is doing fine with all these interventions.
Good.
Thank you everyone for presenting wonderful cases. Now, Dr. Prashant, I just taking over in between so as to expedite. I will request all the experts to give their comments for the last 3 cases plus their take-home messages, because we are actually, thanks for staying on, because we are actually 53 minutes beyond time. Our time is generally for 1.5 hours, but we're going to complete 2.5 hours. So I would request the experts. I can first request Dr. Karna to have make her comments on the last 3 cases and final take-home messages for everyone, and then subsequently I request one after the other. This is a normal protocol to have take-home messages by the speaker and experts. Dr. Karna.
Yeah, no, thank you very much for, I think all the cases were great. I think on the for the dural sinus malformations, I want to say that, it was a nice series. We'll add that when you're reviewing these cases, you want to also look carefully at the white matter for any signs of white matter injury, or obstruction of any of the other sinuses. And I think the same thing, most of them will regress well. They have a good prognosis, should not be a reason for termination. I think if other things are good. For the corpus callosum series, I think we know that the one message, I definitely want to say that you should not stop at just evaluation of the corpus callosum. You need to look at more things because it's associated with a myriad variety of conditions. And I think the paper which Dr. Nitin was referring to, I think they had many of the cases in that series were little older fetuses, so you could have a better evaluation of other structures. I think sometimes you're limited, you can't tell early on what is going on, but it's helpful to come up with these schemes. I think the bottom line is just look at everything, in every case. You can't just stop at the one thing. And I think the last case was very fascinating. I learned about the sanctity pyridoxine deficiency, and I think it was a brilliant case just to keep in mind. And then overall, I just want to say that, the fetal MR is something which will add on. A basic evaluation is to be sonography. You start with the sonography, and then fetal MR can add, in many cases, certain more information, particularly for CNS evaluation. And looking at hemorrhage, we find is one of the big scoring areas of MR and white matter involvement and cortical involvement. I think these are few areas where MR scores over ultrasound when it is subtle. when it is very obvious, of course, everything can be seen on ultrasound, but MR will score in these areas. And I think brainstorming and discussing these cases is very important with the whole team. That would be my message. And thank you very much for the invitation.
Thank you for a wonderful talk. Dr. Karan, just one thing, it was being mentioned about sedating the mom with that diazepam thing. What was your take on that? I just wanted to be clear what you're
We
doing.
do not use any sedation. We have, I think the FDA guidelines are much more strict in US. I know that some centers in Europe do that. Do offer some kind of sedation. I don't think I think it was done in the past, but we don't do any sedation at all. The only one tip we do them, like early in the morning, we ask them to avoid sugary and caffeinated drinks, before coming at least 1 hour prior.
Thank you so much, Dr. Asghar.
I will not add anything more for especially for three cases. The second one is actually the repetition of the other cases, but wonderful presentation, neural malformation, neural symptom malformation. I was added the critical point that in that fluid signal and the ultrasound, if you are doing your ultrasound, the echogenicity inside the cystic structure, which differentiates from the arachnoid cyst. Most of the time, perinatologists send those cases us for the suspect of different kind of cystic lesion with an internal echogenicity. Actually, this is the description of the dural sinus malformation at the torcal area. And look for the possibility of the calcification as well in that structure. If you learn one time straightforward diagnosis for the cases, my take-home message: ultrasound and MRI are not in competition. We are using them in combination. Both are our tools. Whenever we have to know at what time we use each tools. Don't forget whenever necessary to repeat the exam, even for the MRI as well. Second time for cases of especially posterior fossa cases and cortical malformation case, which we need in the 22-23 weeks. But after that third trimester, we also need cortical malformation suspected cases repetition for the MRI as well. And for my invitation, thank you very much for your society. Thank you very much.
Thank you so much, Dr. Nitin.
Yeah, so I think we need to utilize fetal MRI more efficiently, and I am aware about literature where diazepam is not advised in fetal MRI and may not be approved in United States, but there are centers in Europe which use diazepam for fetal to minimize fetal movements. There are articles which doesn't favor it make any difference, but at least in our setting we find it useful. So if we compare, so we have not studied it as yet, but we have seen difference between the cases where diazepam was not given versus when diazepam was given. Because in the past we have seen that at times there were studies where absolutely nothing was evident and we were not able to tell the patients as much what was seen on ultrasound itself. So that in that case the study was completely abolished, that we are not able to look at anything because of the movement. So at least with use of diazepam, we don't face such situation at present. So because the safety literature doesn't talk about adverse side effects or safety as of now, but there are centers which definitely use diazepam. So let's see.
Yeah, thank you so much. Dr. Talukdar, sir.
Every case is nice. They are adding to our knowledge. They are updating our knowledge. And at the same time, very well selected topic, the fetal MRI. Relatively newer technique. Really showing paying its dividends. It is just advancement and advancement. It's excellent. Excellent.
Thank you, sir. Thank you, sir. Lokesh, Dr. Lokesh. take-home messages or any comments for us three? Dr. Indrani, would you like to add something, ma'am?
They have to develop expertise in each place in fetal MRI. It has to work as I said, it's not it complement each other, and then we should have free dialogue about what is the best information we could get from both the modalities. I truly feel we have not used any dialysis pump for the past 15 years, and I would prefer that waiting for the 22 weeks will give you better information rather than this little early. Because now that MTP law is revised in our country, 24 weeks earlier, people used to get very. Because even corpus callosum, I find at 22 it is better because there is always a variability in growth. I find people are very restless these days. They want to get answer as early as possible and then take decision. I think we are here to
Thank
help.
you, ma'am. Yeah,
Okay.
absolutely. Thank you. Thank you very much, ma'am. Mahesh?
Fetal is a new specialty, and earlier we recently developed molecular and sensitivity to take care of these jobs. So it's a very feasible and
Thank you so much. Prashant? Want to add something, Prashant? No? Okay. So I will just thank all the presenters and who have presented wonderful cases and their mentors and all the attendees and of course all the experts. And I'm really very grateful. Thank you so much. And we come back next week with this last session of this SIG for this month, which will be again on fetal neurology. Thank you so much. Thank you. And I think Prashant and Mahesh just stay out. Yeah. Thank you very much. See you next week. Thank you so much. Have a great day, Dr. Karuna.
Thank you,
Bye.
everyone.
Bye. Bye. Thank you very much. Bye.
Bye.